We have none other than Professor Dr. Sudharshan Khokhar, who will be enlightening, the pre-operative evaluation, the sizing, and let us gain to his immense experience from the RPC. And year after year, he has been teaching us and making us more knowledgeable on this. All to you, Professor Khokhar, sir.
Thank you, Sonu. And Sonu doesn't sing. Do you sing? Goel Nigam. Okay.
Unfortunately, no.
But yeah, so let's start the ICL. Now, ICL, as we're talking about, is one of the surgery which is one of the best as of now for the refractive purpose, right? The anxiety is how to size it. So I think that's the only thing I'm going to touch about, sizing. Because we have a galaxy of surgeons here. Dr. Chaudhary is here, his son is here, and I mean, everybody is a great surgeon here. So we'll stick to the sizing. So my anxiety was how to do the sizing. Can I see the raise of hands of people who put in ICLs here, please? Can I see the raise of hands? Oh, lovely, full house. So the commonest size which you put is either 12.6 or 13.2. Is it right? Can I see the raise of hands, please? Okay, so 90% of the lenses are 12.6 or 13.2. All right. So how do we come to that, and why do we have 4 sizes only? So let's make it a little funny now. Okay. The first thing is whenever you try to do this patient, I think that's for the opening for this symposia. No surgery. Any kind of risk I don't want to risk any in these patients at all. Not even a 0.001, because these patients are 20/20 or 6/6 with the glasses or contact lenses. So please don't touch it if you're not confident, if you're not sure that what you're going to do. So no complications is what we want. And second is the myopia is not going to stop. So if there's a retinal changes in the myopia at the back, please tell the patient he still has to come up, follow for the retina checkups every 6 months or only, depending on whatever the pre-status is. And if they have a hole in the retina, please laser it, plug it, check it in another 4 to 6 weeks, then only go in for these intraocular surgery. Okay. All right, so this, if you see the first chart on the right side, on the top, is the average height of the male. I'm talking to the males, it holds true for the females also. That's 2019. So you see there's a variation, there's lots of variation. So if you want to measure, buy a shirt from the market, what are you going to check? You're going to check the collar size, you can do the chest size, you do the waist, you do the shoulder, you see the sleeves, and then you see the length. Okay? Fine. So this is what average male is. Mr. Average in 1961 was something, in 2017 it's changed. So it's changing. But fortunately, the eye size does not change that much. Once the guy becomes mature, whatever the size is there, it stays. So because there's a variation, you have a variation. So if you might be lucky to get a shirt ready-made which comes and fits you, you might have a cuff which is longer, you might have a collar which is not fitting you well, whereas in the ICLs, even if there's a mismatch of a few millimeter here and there, it's not going to worry much. I'm going to show you with the experimental things, which I'm going to show you some here. Okay, so if you see, this is what the ICLs are. You've got a 4 sizes for the myopes and 4 for the hyperopes. The one in the yellow are myopes and the one in the orange are the hyperopes. So smaller lenses for hyperopes and the bigger lenses for the myopes. All right. So when the patient comes to us, what are the pre-op assessment? First, you do a good refraction. If your refraction is wrong and that's what you feed onto the sheet for the calculation, so garbage in will be a garbage out. So you have to be very accurate about the refraction. Please do a Duchrome test in your own hands in the at least first 100 patients, so that you don't have any problem, or you get a good optometrist for that. Then comes the sizing. So sizing, why is the issue about sizing? Because what you measure is white to white, and you're putting the lens in the sulcus. So you need to have formulas which tells you that if this is the white to white, what is going to be the sulcus. So if you go and see, and the best way of doing it is a UBM, but and most of the people might not be having a UBM to measure sulcus to sulcus. But certain patients in which you find there's an anomaly on measuring with the calipers and with the OpScan or a pentacam, there's a difference. In those patients, you might have to come down to the UBM to pick up the actual size of the sulcus. So white to white, what the dictum says, it's if you say the white to white, you add 0.244 to it becomes the sulcus to sulcus. Is it correct? And how have we come to this? There could be undulation and anatomical changes behind the iris which you can't see. So it might not be true for all the patients. Okay, so this is what the sulcus looks like if you see from the back, and there could be undulations in the periphery which can cause a problem. So this is the article which I'm quoting. This is an article by Pope and et al., which JCRS 2000, and there were 2 people, Fia and Pope. So what they did was they measured the white to white, angle to angle, and sulcus to sulcus in these patients. The average they found was 11.7, 11.9, and 11.2. But how did they reach to this conclusion was they used a UBM probe of 50 megahertz, and 50 megahertz probe will give you a big image. So you have to have 3 images put together to actually make a collage and measure it. So this is what they used to do. So they have to put all these 3 images. So the error by putting these 3 images on each other was itself more than a 0.75. Meaning that this article you just cannot use for your extrapolation to the actual size. All right. The better would have been if they used the 35 megahertz, which gives you through and through. If you can see here, through and through, this can be measured with a 35 megahertz probe only. Okay. So the sizing still remains a challenge. That's why I'm sitting here. You can try any of these modes. We found OpScan was a very good machine which has a slit scheme technology, so it used to start scanning from one side to the other, and you give you very accurate data. I don't know why the machine has gone out of repute and it's not been available anymore. They have Pentacam, but Pentacam always gives you a little higher number, so your lens size might differ. So the caliper down here is very good to measure. Even my golf ball, if I put there, it'll give me a good accurate measurement. Okay. So what you need to do is, whatever machine you're using, you have to keep calibrating it again and again to check that you don't have any errors in these ones. And there should not be too much difference in both the eyes. If there's a difference, then I think the mechanical measurement is the best, or you can go for a UBM measurement on a sulcus to sulcus on a UBM, a 35 megahertz UBM. Okay. All right, we come here. So why only 4 sizes? Is the question we can ask the company. So there was a study which they did in which they actually picked up people from 10 years to 80 years of age, a huge number of patients in this one. And they found out that the average diameter was 11.7 plus minus 0.41. And this is a study in which they found out the average male size varies from 11.4 to 12.5 for the males and 10.7 to 12.58 for the females. So if this is what they could find, they actually got it in the 2 standard deviations. So if you can come into this range, 95% of your 99% of your population will actually fall into this one. So it's a good study. So the 4 lenses are good enough actually. Okay, so what happens if the lens size is smaller, it will have a lesser vault, but it can cause cataract. If it's a higher one, you have a higher vault. So what happens? Let's see what happens. Okay, so all right, let's go there. Now this is one of the chart which was given to us about 10 years back, in which they said that the ideal vaulting is between 250 to 750. I would like to change it now. My ideal vaulting should be between 500 to 1000. I want it a little higher vault. So all these surgeons, if you have an option to pick up a lens, please go for one which is higher. With a V4C model with a hole in the center, it's not going to make any difference, and your high vault will sustain for longer. Each year you're going to lose about 25 to 28 microns of the depth of the vault. So if you got a little higher vault, it'll help you better. So the patient, by the time he comes to the cataract age, he'll still be having a vault around a 250, which is good enough. Okay, so these are some examples of the good vaults. I think all of know that. So let's come to the ones which I want to talk about. So this was a slides given by the company. They picked up the lens and they did some mechanical tests. So see, this lens is a 12.6, 10.5 is the power. And if I do a compression, 1 millimeter extra, 1 millimeter, that means 12.6 becomes 13.6. Which is huge. Okay, so this is what happens. This much is a high vault. You can appreciate the vault. So what happens with the vault going up? So if you see the force and the vaulting, you realize that for each 0.1, it's only 5 milligram, and it's 0.11 millimeter, which is higher. So if you have a 0.5 millimeter extra lens, it's not going to make much of a difference. Okay. So this is the article which say that every year you're going to lose some vault. So I already told you about that. So I'll skip it. So your aim has to be to pick up the highest possible vaulting without having a defect in the refraction. That means if the lens goes too much anterior, your power might change. For a hyperopic lens, if it goes more in the front, it becomes more effective. So you have to reduce the power by 0.25, and if it's a myopic, you go the other way around. So this is one of the examples I'll give you. This patient was done in 2008, and now it's already more than 14 years now. So we put a 21.5 diopter and 120 was used in this patient. Now the patient is 6'9", there's a peripheral touch, and this was not a V4C model. So this patient is actually touching the periphery, but the central part is vaulting about a 200, 180 to 200, a very low vault in the center. But the patient doesn't want a surgery, but there's a peripheral touch, there's a cataract there, it's not progressive, it's localized to that area, and vision is 6'9", so we're just following this patient up. Okay, so when you calculate the power, what do you do? There are only 2 things which you can measure actually. You do an anterior chamber depth anything less than 2.5 and 4.5, you can't put an implant because the machine is not going to take it. So if it's more than 4.5, say 4.6 or 4.7, you have to still put 4.5 only, otherwise the machine won't take it. And the second is white to white, between 10 and 13.5. Okay, so if your corneal diameters are less than 10.5 millimeter and more than 13, please do not buy a ready-made shirt. Do not put ICL for these patients because we don't have any lenses. And the ACD is less than 2.8. So the answer is no. Okay, now we got what? 11.11, 11.5, 12 and 12.5, and that's what we have. So these four groups with two parameters of ACD, which is less than 3 and more than 3. So if you can put these together, you can have this algorithm and you can actually pick up the lenses which you want. So if, for example, if it's a 11 diopter across less than 3 and more than 3 millimeter, that's a ACD. From the endothelium. Okay. So if I put a 12.1, it will be a high wall for me. If I put a one higher than that, it will be a moderate. It will be low volt actually. But if I have 11.5, I can have two options here. I can have a 12.6 with a high volt and 12.1. Basically, we have got 4 lenses to play around with, and most of the time you have confusion with 2 powers, which is 12.6 or 13.2. Majority of them, that's the issue. In my own data, which I checked for the last, I think, 15 years, 96% of the patients were either 12.6 or a 13.2, and we have not explanted any of the lenses because of a poor volt. I'll just take 2 minutes more. So similarly, you can go see this data. I think you know this one. I've been presenting all over. So if the 12.5 is across less than 3, you have a moderate with a 13.2, and if you go for the high volt, then you have a 13.7, which is the maximum. So if your demand is more than 13.7, please do not put an implant in these ones. This is not going to do well in any of the people. So if you have a myopic, you can actually calculate the power 0.25 higher, because minus number going away from the pupil, from the lens area in front will have less power. So you put 0.25 extra, and for the hyperopes, you can reduce it by 0.25. Okay, so this is what I'm going to show. If you put the lenses properly, a volt is going to be fine. And even if the volt is a 0.5 up and down, it actually is not going to cause any problem in these patients. Thank you very much.
Thank you, sir, for that wonderful talk. Any questions for Professor Dr. Khokhar?
Dr. Khokhar,
So before
Sure.
what is the minimum volt you will like to leave, and what is the maximum volt which you are going to, which is without the rise in intraocular pressure which you are going to leave?
So I think all these patients, you're going to do a gonioscopy before the surgery. So if your patient's an angle closure, a prone angle closure, you're not putting implants in these ones. Okay. So I'm taking the factor away. So what you're saying is, because of the volt, how much is the angle closure happening? That's what is the question, right? The pressure going up because of the angle occlusion.
Pressure is normal.
Okay, if the
only the volt is high.
It doesn't make a difference.
Only
if the volt is good,
high,
the pressure not going up, only the power can change a little bit, and that you can adjust beforehand. So if I'm picking up at 13.2,
what is the
vaulting
maximum volt which you are going to say without any rise in intraocular pressure?
I'm following the patient with the 1000 plus 1100 volt. Also, I'm following the patient for last 4 years, and nothing has happened, especially with V4C. And the volt is going to go less every 28 micron every year. So you follow them, and it's going to go less. So it's not, doesn't make a difference. So don't be in a panic to take the lens out if the volt is high. If the pressures are good and the pupil is constricting well, if you don't have a Urey-Zavalia kind of picture, then of course you can leave the lens alone. And my take is that you keep it 500 to 1000 volt. Don't stick to 250 to 750, which was earlier recommended.
And what is the lowest volt which you will?
250 is the lowest.
No.
Okay. I'm following this patient.
If it is 180, 170, 160 volt.
With V4C model, you can have a liberty with a hole in the center. You can have a liberty of going a little low also. Now, these are the patients which are in the extreme. So that means if you really, the kid is saying you want to have this shirt only and it's available in this size only, and he doesn't want to wait. He doesn't want to go to a tailor to get a thing made. Then you have to fold the sleeves, you have to adjust to the shirt. But yes, anything between, even if it's 150 micron with the central hole lens V4C, we have followed these patients for 5 years, nothing happens to these ones.
So, Dr. Khokhar, you still use anterior crystalline lens rise for varying your size of ICL in borderline cases, you were like 11.6 or 11.7. Because that makes a difference.
I think that's a very good question he said. Now what he said is a lens rise. Lens rise means we're looking for the straight, and for the near, the lens changes the dimension and the lens also gets pushed up. So there was a study in which they found out that the lens rise happens, it's similar. Even if the patient is looking straight for the near and the distance, the rise does not make much difference. Even that article which says 28 micron it changes, talks about the lens dynamics and rise. what Dr. Arun is trying to say, that if you have a borderline cases, those are the only cases where you can actually get stuck sometimes. But for the majority of the patient, if you're right in the middle with a true standard deviation on the side in the Gaussian curve, I think 99% you'll get away with that. So you don't panic. Please wait for these patients and these lenses settle down. Yeah.
Yeah.
So I think there is.
I have one question.
Sure.
Of course, you got the message from here that all these ICL with the central hole, the chances of cataract is negligible.
Sorry.
Can you
Can you
please
use a mic,
switch off the.
Guys, can you please people switch off your cell phones for 10 minutes? Because after that you can put it on. Anyway, for the session, I'm sorry. Okay. Sanjay, please.
So, we got this impression that with ICLs with a central hole, the incidence of cataract is almost negligible.
Yeah.
However, you showed us a slide.
Mic, huh?
You showed us a slide
Yeah.
where the old version, V4,
Yeah.
without the central hole, there was a peripheral cataract developing. Now, for a lot of us who still wonder whether we should intervene in such a cataract, take out the lens, and will the cataract progression stop? Or we just let it be and let it go on towards full cataract and remove the cataract?
Okay, I think that's a very good question. Now, what happens is when you see a vault, what do you mean by vault? Vault means that you can't flatten the lens on a horizontal platform. It has its rays in the center. So the periphery is where the lens is touching in that patient which I showed you. And we gave the option to the patient. She didn't want a surgery and she's 6'9" years, so we're following it up. They will not form a central cataract, and these cataracts do not progress. They stay localized to that area only. They do not progress. Something like if you do a peripheral iridectomy in this patient of a glaucoma patient whose angles are shallow, you might have a little cataract forming there when you are very aggressive in making the hole. Especially in the Indian irises, you make a hole, it's small, you want to make it bigger. You can have a localized cataract, but that does not progress down all the way. Is that clear? Okay, anybody else?
So just last two questions for the
Sure.
interest of the general audience. Give me two equipments, one for the white to white and one for the ACD, which I want to purchase so that, I can be rest assured that I get the most reliable or the accurate measurements. So
Perfect.
number one is white to white, which is your most, which you say is the reliable tool to measure white to white.
I think the digital caliper is the best as of now. Earlier I had an OpScan system, which was a scanning slit beam. I don't know why they stopped. Now all these pentacam with the sheen flux and all those, they always over-calculate. So you can't actually rely on that. So if your digital caliper, which comes for, I think, 5,000 rupees, you can pick up these Japanese digital calipers. They work wonderfully well, which I showed you there. Pentacam we do for remeasuring, reassessment of those ones. Otherwise, I think a simple caliper is good enough. Anterior chamber depth, ultrasonic is the need of the hour. That's the best. You can't use the sound there. You can't use the OCT because there will be so much variation in that one. So ultrasonic depth and cornea thickness with that only, and remove the cornea thickness from the entire, and you use a digital caliper.
So nothing fancy required to start an ICL practice.
Yeah.
A simple caliper is what is required, and then anterior chamber depth, what he said, measuring with an ultrasound.
Yeah.
Or do you think pentacam also is inaccurate in measuring the ACDs?
See, it can help you. See what happens now, once you're doing your ultrasonic, and then you can assess with that. So if you can, the problem happens when there's a difference in the anterior and the posterior growth of the eyes. I get sometimes eyes which are nanophthalmic. Those are the one, and the curvature is different. In those ones, the white to white is never going to be giving a good, accurate assessment of the sulcus to sulcus. So those are the patients in which I have a UBM of 35 megahertz where I use it. I use it not very often. So what I started doing, I was doing in all the patients. Then I realized most of my data from the UBM is coming the same. But in certain set, maybe 1 to 2% of patient in which there's a anatomical difference, nanophthalmic eye, a growth in the anterior posterior is not going hand in hand. If the patient is at 13, 14, 15 myopia and the axial length is not too much, so that means the chamber depth is more in this and not at the posterior. Those are the patients, if you can use a UBM in those ones, you will never fail.
Thank you very much, sir. So